Good morning, everybody, and apologies for the technical difficulties I've experienced at the beginning. We are going to get right back on track. We are going to have a lovely webinar today by Dr. Luca Longhi, who is an anesthesiologist and critical care doctor in Bergamo, Italy. The webinar is going to be about the pathophysiology of acute brain damage. Just as a reminder, you can use the Q&A box in your Zoom controls to send questions that Dr. Longhi will answer at the end of his presentation. And now I'm going to pass the slides to Dr. Longhi for his presentation. Thank you very much.
Good morning or good afternoon, depending on where you are. In the next 40 to 50 minutes, I'm going to talk about the pathophysiology of acute brain injury. And in particular, I will focus on traumatic brain injury, TBI. I will focus on subarachnoid hemorrhage, SAH, and with a specific focus on oxygenation and metabolism. At the end of my presentation, I will share with you some of the preliminary data that we obtained using the Moberg system last year. So this is something that it's clear to all of us. And when we talk about the diseases that we treat in neuro-ICU, we know that usually there is a primary damage, and if we think of TBI, this is the damage that is due to the biomechanical forces of the impact. Right after, there is the activation of a cascade of pathways at physiologic, cellular, and molecular level. And there is not that much that we can do to change the secondary damage. But we know that there are insults, and I've listed some of them in the slide. And basically, our job as intensivists is to prevent, to treat, diagnose, and treat these insults as soon as possible when we see them. But to date, we have also several guidelines. Basically, for every condition we treat in the ICU, we have guidelines. They are built on evidence-based medicine, and for sure they are a good starting approach. But in many cases, they're not enough, because for many questions, we do not have yet evidence. I show here the classic staircase approach to ICP management. And this is something that was used for years. You see here in the left of the slide that there are like steps of therapy. You see the level of evidence of each of the therapy, and then the classic staircase approach. This is practical, is effective, and is very pragmatic, but it has a limitation. And for a better treatment and a better approach, it would be better to understand the cause of increased brain volume. If the problem is hyperemia, probably it makes more sense to reduce the blood volume within the brain, and not to, for example, start with hyperosmolar therapy. A step towards this philosophy was recently shown in this consensus, and indeed you see that ICP is treated according to 4 scenarios. And the first one, everything is okay, and then we may have to treat intracranial hypertension according to the level of brain tissue oxygen tension, PbTO2. And in case B or case D, the treatment is different, or may be in part different, because of the pathophysiology of brain oxygenation. So I think that the future will be that of precision medicine. So to try to individualize the treatment of every patient based on his physiology in a particular day, in a particular time course of his disease. We talk about TBI, and these are 3 patients with TBI, but I'm sure that we all agree that the patient with the epidural hematoma is quite different in terms of pathophysiology and treatment from this patient in the middle of the slide, and in this and also of these patients with traumatic axonal injury. So most of the conditions we treat in the neuro ICU are characterized by heterogeneity. In order to individualize the treatment, we need to study the physiology. And as a very basic, thinking of blood flow, oxygenation, and metabolism, these slides show that the brain is a very limited part of our body. It's roughly 2% of our body weight. However, even if it's a little part, it receives up to 15% of the cardiac output. It uses up to 20% of our oxygen and 25% of our glucose. So the brain requires mostly oxygen and glucose to produce energy. And in physiologic condition, the brain uses the energy mostly for neuronal communications, 60%, but also to produce transmitter, transport them within the neurons. And so there is also a housekeeping requirement of energy. There is no possibility for the brain to store the nutrients. The glycogen capability is very limited. Therefore, the brain requires a constant delivery of oxygen and nutrients, mostly glucose. This is very basic physiology. What happens in pathology? So we know that after traumatic brain injury, this was an experimental work published roughly 30 years ago. And in this part here, you see a coronal section of a rat brain where there is the red arrow. There you see here a lot of red signals. This means reduced cerebral blood flow, CBF. And indeed, you see that there is a reduction in CBF starting minutes after the injury, and then with a return to the baseline value within hours. What happens in the same time to metabolism? This is another experimental work. Always, it's still lateral fluid percussion brain injury, and you see below the arrow again a lot of red signal. But this increase in red signals is increased in glucose metabolism. So we have a mismatch between reduced CBF, oxygen and glucose delivery to the brain, but the brain at the very beginning requires more glucose uptake. And this is also shown by the increase, as you see here, in the extracellular lactate concentration within the brain by using intracerebral microdialysis. Why does the brain need to use that much glucose? Because here it requires energy. And it's clear now, we know that after the injury here, you see that the depolarization causes a massive release of potassium, the red circles, within the extracellular space. And at the same time, there's a massive release in glutamate, right minutes after the TBI. In order to restore ionic gradients, the brain needs to put back the potassium within the cells. And this process requires a lot of energy. Glucose metabolism is a key at the very beginning to produce this energy. What happens to CMRO2, that is the cerebral metabolic rate of oxygen? This was a seminal paper by the group in Philadelphia showing the association between the degree of consciousness reduction after TBI and CMRO2. And you see that there is roughly a linear relationship between consumption and severity of TBI. The most severe the injury, the most depressed is oxygen metabolism. Why does that happen? Because it has been shown that after TBI, there is a mitochondrial damage. And this part here, you see a sham-injured of animals. So this is a control, the green rectangle, and you see normal mitochondria. In the right part of the slide, at 24 hours after TBI, you see in the orange a swollen mitochondrion, and in the red, you see a ruptured mitochondrion. Therefore, TBI induces a mitochondrial damage that is then responsible, and it is associated with a reduction in oxygen consumption of the brain. So we have seen that the CBF is reduced at the beginning, the glucose metabolism is increased, the oxygen metabolism is reduced. And we all know that the group at UCLA has shown that there is something called metabolic crisis. And this is defined using intracerebral microdialysis. And here the cutoff, so when the extracellular glucose concentration is below a certain value, and when the lactate to pyruvate ratio is above 25, this is a condition of metabolic crisis. In this condition, the brain is still viable. There is not necessarily a damage destroying the brain, but the damage may occur when there is a secondary insult. So if we are in a crisis condition and there is a seizure, this increases the metabolic demand, and this may lead to histologic damage. Similarly, if we have a hypotension reducing CBF, oxygen, and glucose, therefore the nutrients for the brain are reduced in a moment in which the brain is vulnerable. A key for neurocritical care patients is the definition of ischemia, because we have two approaches. In this slide, you see the classic definition, which is based on a threshold. When the blood flow is below 18-20 milliliters per 100 grams per minute, usually this is the classic threshold for ischemia and stroke. When there is a reduction in CBF, at the beginning, the neuronal function will be okay. Below the threshold, we will see a clinical dysfunction and a change in the EEG with a tissue that is still viable. When the blood flow usually is below 10, then we see, the clinical sign, but also we see an additional change in the EEG with membrane failure and then cell death. What happens, or what can the brain do during this progressive ischemia? You see in this right part of the slide, reduction of CPP. There is a lower limit of autoregulation that may be different patient to patient. And you see reduction in CPP, reduction in CBF. The physiologic compensatory response to reduction in CBF is an increase in the oxygen extraction fraction. So the brain tries to take more oxygen from the blood, and this happens here. And when the brain increases the uptake of oxygen, still the CMRO2 is preserved. Up to a certain point, there is no further capability to increase oxygen uptake. And therefore, above this limit here, the CMRO2 starts decreasing. And this then is associated with EEG changes, ionic shift, as discussed previously. So this is one definition and one approach to ischemia that is perfect for stroke. But ischemia is for other conditions such as TBI and in some cases also FSAH is probably better defined by a balance. So we do not stick on a threshold, but on a relationship between oxygen delivery to the brain or to a part of the brain and CMRO2. And the gold standard to define ischemia is using oxygen-labeled PET. The principle is based on the level of oxygen content in the venous side of the brain. It has been shown that when oxygen content, the venular oxygen content is below 3.5, then we are going to have like a penumbra-like condition leading then to tissue damage. So using PET, we may measure the oxygen extraction fraction, which is critical, which is the threshold above which the venous oxygen content decreases. In this PET here, you see a patient with subdural hematoma. A lot of red here means reduced CBF. A lot of white means ischemia. So in TBI, we know that the CBF is reduced, but we also know that CMRO2 is reduced. So the definition is better obtained using critical oxygen uptake using PET. Recently, last year, there was this very nice paper published by the group in Cambridge, and we see data from 20 healthy controls and 78 patients. They underwent 90 PET sessions. Some of them at the very beginning, the first 24 hours after TBI. There is an intermediate group at 2-5 days, and the late group after day 6. Let's start with global physiology. This is the part of the controls. So we see that, as we already knew, overall decreased CBF, increase, this to me is unexpected because there is an increase in the cerebral blood volume, suggesting that probably kind of hyperemia is a key for intracranial hypertension. There is a reduction in oxygen metabolism and a reduction in oxygen uptake of the brain. However, this is the global picture, but let's focus a little bit on details. You see here a CT scan with a patient with a frontal, a right frontal contusion, and another bit of contusion here. And look at the PET scan. Okay, the core of the contusion is destroyed, but in the same brain, a part of hyperemia increased CBF, and you see that the oxygen metabolism is very different and the oxygen uptake is different. So huge heterogeneity. Why is that important? Let's think of brain tissue oxygen monitoring. So now there is kind of consensus. We would put the probe here in the contralateral frontal cortex, contralateral compared to the contusion, but a little probe cannot catch the entire pathophysiology that is occurring in this brain. In addition, they have characterized the temporal course of what happens after TBI. And the red part, the red line here is the median value of controls. And here we see CBF very reduced in the first 24 hours, then an increase at 2-5 days, and then again a decrease. Let's look at the oxygen extraction fraction here on the very right. And we see that in the very first few hours, we have an increased oxygen uptake. So the first few hours mean real ischemia. It's not just based on a threshold, but on a balance between oxygen delivery, oxygen consumption, and uptake. And then after the first day, there is a phase of reduced oxygen uptake. So if we think of brain oxygenation, the soonest we start the monitoring, the greatest is the possibility to detect ischemia that we know occurs in the first 6, 12, 24 hours. What about the relationship between other conventional monitoring system for oxygenation? Because we do not have PET scans, only in few selected centers. In this part here, we see the association between the ischemic brain volume calculated on a PET scan and SGO2 saturation. And we see that in order to have a pathological SGO2, we require more than 10% of the patient's brain to be ischemic. So it's not a sensitive monitoring system. And what about the association between PbTO2 and PbTO2 and ischemic volume? Below 20, which is an accepted threshold, there's not that great relationship. So I think that all these systems provide complementary information. Okay, we, as I say, do not have PET availability in all the centers. So what can we use to evaluate brain oxygenation? More than 20 years ago in Europe, we started with PbTO2 monitoring. This was a seminal paper published by the group in Rotterdam. And in the left part of the slide, you see the temporal course of PbTO2 in survivors and in patients who died after TBI. And it's clear that, in particular, in the first 12, 24 and 36 hours, there is a difference between survivors and patients who died. And also, we have seen that there is a probability of death according to the time spent below 15, 10, and 5. So brain hypoxia occurs after TBI, and the most severe is the hypoxia. The longer duration of hypoxia, the increased probability for patients to die. A few years later, the group in Philadelphia published this paper, data on 19 patients that started PbTO2 monitoring within 6 hours after injury and with a good resuscitation. ICP could be probably better below 20, but CPP was at least 60. And almost half of the patients were hypoxic, mildly hypoxic in the brain. 1 out of 5 patients with good resuscitation was severely hypoxic, with a PbTO2 below 10. So for sure, hypoxia is a problem in our patients. If there is an association between hypoxia and bad outcome, it makes sense to start treating hypoxia. And 3 years ago, there was the BOOST phase 2 trial showing safety and non-futility. So it is worth to investigate an approach aimed at treating hypoxia. Now it is ongoing, the BOOST 3 trial, testing the hypothesis that TBI patients handled both based on ICP and PbTO2 will be better compared to patients with just conventional ICP monitoring. So we will see the results of our patients. The point that still isn't clear, I haven't shown you the protocol of the trial, but a problem of treating regional hypoxia is what is the best way to do it. In the protocol, there are several approaches. We just need to consider that the oxygen delivery to the brain is dependent on cerebral blood flow and arterial oxygen content. How can I raise CBF? PaCO2 is an option as one of the steps that is suggested, but mostly and classically is CPP. Oxygen content is dependent on hemoglobin, its saturation, a constant linking oxygen and hemoglobin, and also PaO2. But this seems to be a very little contributor to oxygen delivery. So to date, it's still a bit unclear the best strategy to treat regional hypoxia, and probably also this strategy should be individualized. This is a very, very elegant paper published again by the group in Cambridge, and they performed they investigated 20 healthy controls and 10 TBI patients. The interesting thing is that the patients underwent two types of PET scan. The classic, that all we know, oxygen-labeled PET, but also this new PET here, which is the 18 fluorine label F-meso. Meso is mesonidazole, and it is a tracer that is taken by the hypoxic cells, but when they are still viable. So this tracer undergoes a bioreduction and it becomes visible at PET. So in this slide here, you see MRI, bifrontal contusion, another lesion here, and this is CBF, this is oxygen uptake, and this is the ischemic volume. So you see several scatter dots of red signal, which is ischemic brain volume. Then we see hypoxic brain volume, and this is this different red. So we have understood that in the same brain there are areas of true ischemia and areas of diffusion hypoxia, which is a very microvascular ischemia. If we compare the physiology, HBV is the hypoxic brain volume, IBV is the ischemic brain volume. The CBF is reduced compared to controls. There is a difference in blood volume. This is important because in hypoxic brain volume, the blood volume is reduced, but the most important difference is the difference in oxygen uptake. Increased uptake is ischemic brain volume, reduced uptake is hypoxic brain volume. So it's a different pathophysiology, and this may require a different therapy. Indeed, again, the group in Cambridge published this other paper, and they used MRI focusing on diffusion tensor imaging, 14 patients, and basically they highlighted some areas of the brain, the core of the contusion, here the black, the mixed intensity tissue is the part of the contusion with mixed blood and edema, and then there is a pericontusional ring, it's 1 centimeter of what we know is cytotoxic edema. It's highlighted here. The patient received 2 images. The first one with the basic condition of hemorrhage, as we usually have in ICU. Then the patient underwent 60 minutes of hyperoxia to these values, and then they underwent a second scan. I show you these little orange red signals. These are the apparent diffusion coefficient, ADC, change after hyperoxia. You see this area of cytotoxic edema, and it seems that hyperoxia is able to increase ADC up to normal values, suggesting that for regions which are hypoxic, such as the pericontusional tissue, hyperoxia may be a potential therapy. My thinking is it worth, in order to save a little part of the brain that may die in any way, to give hyperoxia for hours or for days, because hyperoxia has also contraindications. So I do not have an answer, but this is something to think of, because pathophysiology becomes clear and clear and clear over time. When we talk about PbTO2, there is another aspect of physiology that we should consider, because, okay, I can say I want to increase CPP, I want to give more oxygen, but the important point is time. And this is another experimental, very elegant work, coronal section of a rat brain, a model of middle cerebral artery occlusion. This is the contralateral hemisphere, blue, perfect PbTO2. This is the penumbra, so the tissue that we would like to save, and it's green, 20, right below 20. So this makes sense. There is hypoxia. And this is the dead part of the brain in this model of stroke with very, very low PbTO2. What happens after reperfusion? It happens this. So the contralateral hemisphere stays stable. So PbTO2 is still normal. And penumbra, the green, the mild hypoxia is basically normalized. So reperfusion is okay. In the core, the reperfusion is associated with a massive increase in PbTO2. If I just consider PbTO2 and I'm not aware of this condition, I think, oh, in this moment, this red tissue or this red oxygen in this tissue is much better. It's not the case. So when we consider PbTO2, always we need to consider tissue viability. In ideal condition, that could be done using microdialysis. If we do not have microdialysis, it may be that EEG may give us a clue on tissue function. Another application of applied pathophysiology is related to the concept of CPP, because it is very clear that, or it's clear that we should start treating intracranial hypertension at a threshold between 20 and 22, it depends. But what is not clear is CPP, because we may have patients, same disease or same patient, different days with preserved autoregulation, with autoregulation which is shifted, for example, to the right, or with no autoregulation. Or in the same day, different areas of the brain may share this characteristic. So by using integrated monitoring, it's possible that we can individualize the best CPP for every patient for that given day. And in this example, you see based on PRX and the oxygen reactivity index, which is the linear coefficient, the moving linear correlation coefficient between CPP and PbTO2, we may find out that for a patient, 60 to 65 is a perfect CPP. For another patient, we require 90 to 95. So the setting of CPP should be very individualized. David Menon wrote this editorial almost 20 years ago. It's still true. We don't have a real idea of the appropriate CPP for every patient and for different areas of the brain. I think that the best way to try to guess is by studying physiology. Moving from TBI to subarachnoid hemorrhage, we know that this is a hemorrhagic condition, but when we fix the aneurysm, the big issue after ACH is ischemia. A lot of studies investigating vasospasm, but it is better for me to consider ischemia. Indeed, in this meta-analysis, it has been shown that putting together more than 8,000 patients, there was an association between lower infarction and better outcome. This is an MRI showing time zero hospital admission in a patient with a ruptured aneurysm of the communicating artery. You see that right immediately after admission, using diffusion MRI, even if the aneurysm was here, we see ischemia in remote parts of the brain. And this is very acutely. Then this can be seen 8 hours later, also using a T2 images. So we have understood that after SAH, there is a phase of early brain injury. That is the result of what is happening when there is the rupture of the aneurysm, massive increase in the subarachnoid blood, intracranial pressure, and this may lead to a global ischemia that may cause a damage and may cause otherwise an increased vulnerability of the brain. And these are all processes that we are understanding. Another key, talking about autoregulation, this massive increase in ICP leads to a kind of vasoparalysis, leading to loss of autoregulation that may result in hypoperfusion and ischemia, or in hyperemia, brain edema, and intracranial hypertension. Indeed, in this paper, it has been shown that there is a clear association between the autoregulation by using oxygen reactivity index and the long-term outcome. So worse autoregulation, worse outcomes. In terms of intracranial hypertension after SAH, we published this paper investigating more than 100 patients with SAH. Intracranial hypertension was seen in more than 80% of the patients, and prolonged intracranial hypertension lasting more than 12 hours in one out of 3 patients. The worst day was day 3, but intracranial hypertension was basically a problem of the entire first week. And at multivariate analysis, there was an association between the greatest mean ICP lasting 12 hours and mortality, not with functional outcome, meaning that if the patients die in the beginning, they probably die because of intracranial hypertension. If they survive, then ischemia is mostly a factor associated with bad outcome. In SAH, we are very scared. If the patient survives the first 2-3 days, then we are very worried about delayed cerebral ischemia. Here it is how it is defined, and about the occurrence of a new cerebral infarction within 6 weeks after SAH. And these are the features of a new cerebral infarction. Putting together all the pathophysiology of SAH, Locke MacDonald wrote this very nice review paper more than 10 years ago, but still is perfect. So these are all the issues leading to brain damage in SAH. Here, the temporal course. So the early brain injury, the first 2-3 days, basically bleeding, rebleeding, perihematoma, ischemia, iatrogenic complications are the leading factors to brain damage. Then, after day 3, usually we are worried about vasospasm or cortical spreading ischemia. So we always try to find a way to detect this damage here. No time, but another mechanism associated with the brain hypoxia may be impaired electrical activity, even if it is not convulsive. This was shown by the group at Columbia, and you see here at DSA, a seizure, non-convulsive seizures, and a reduction in PbTO2. So if I should think of monitoring a patient, I may have different scenarios based on different physiology. So for TBI, my idea is to start as soon as possible. And also in the BOOST trial, they tried to enroll patients as soon as possible. In SAH, it depends. If my goal is to define early brain injury, okay, I can start early. But if my goal is to detect and treat delayed ischemia, maybe that it is worth to be aggressive with monitoring in this condition. Also, an important point is the clinical condition of the patient. Now I'll show you the last few slides showing how we use the Moberg to try to investigate few aspects of pathophysiology. So we all know that there is a relationship between CBF and EEG. This was very clear from years. So we have an ischemic threshold, an infarction threshold, and a change with the progressive reduction of CBF in electrical activity. Indeed, this meta-analysis shows the studies that have investigated investigated the alpha-delta ratio, so the AD ratio, as a diagnostic clue predictor for delayed cerebral ischemia. The first paper was published by Jan Klassen at Columbia, and you see that he set a kind of threshold, more than 10% decrease for 6 hours. And then other groups, basically same criterion plus more than 50% reduction for an hour. Okay, so using the Moberg, we have the possibility of evaluating the AD ratio. This was our setting, so these are the points of EEG monitoring we have used in our center. This is our conventional approach with electrodes that allows us to divide the brain in different regions, like this anterior, posterior, and left hemisphere, right hemisphere. And if AD ratio is a marker of ischemia, we wanted to investigate if we were able to see EEG changes with a positive control test, which is a hyperventilation test, because we all know that hyperventilation induces vasoconstriction that induces a reduction of CBF, not ischemia, but CBF reduction. 15 patients, mostly vascular, this is age. We changed CO2 from 36 mercuries to 27, keeping other variables stable. And we have shown that baseline 36, hypocapnia 27, there is a huge and consistent reduction in the AD ratio. So left, right, anteriorly, posteriorly. So AD ratio using the Moberg is a very sensitive tool to detect CBF reduction. So this was an important finding, but also because several processes happen in the brain in the same condition, we tested the hypothesis that when we have changes in temperature, it's possible that there is a change in EEG activity. The literature does not help us very much. Just by searching with these keywords, you don't find too much. You don't find almost anything. So we evaluated pieces of EEG of this duration at different temperatures, normothermia, hyperthermia, normothermia, and putting together the data of 14 patients and comparing AD ratio, this temperature against this temperature, keeping everything stable, MAPS, PaCO2, sedation, we found that fever is associated similarly to what happened to hyperventilation, to a consistent reduction in AD ratio. Not posteriorly, it's almost significant, but for sure for the other parts of the brain, we have seen that there is this striking reduction in AD. So going back to this paper, okay, they have seen a reduction in AD ratio. Was that always ischemia? Was a reduction in CBF? Was fever? Was something that happened? This tool is very sensitive. It's not too specific. For this, it's very important to combine all the data together with multimodality monitoring, observing what is happening to one aspect, but also to all the other aspects related to the patient. So in conclusion, I think that in order to treat at best our patients, okay, we have guidelines, but we need an individualized therapy for our patients, knowing the specific physiology of each patient. In order to understand physiology, we need to measure it with invasive, non-invasive systems, but it's important every day to measure the physiology, and it's important to try to quantify the data. So not just to see, okay, in this moment, PbTO2 is this value, EEG is this one, and the CPP is this value, but we should try to have a quantitative trend over time. Thank you for your attention.
Thank you very much for the presentation. This was really appreciated. I want to remind everybody to post their questions in the Q&A box through the Zoom controls. And while you do so, I'm also going to remind you and invite you to subscribe to our newsletter that is sent out more or less monthly, and it brings you news about publications, upcoming events and shows where you can find us, due dates for abstract submissions, industry news, and so on. And if you want to contribute to our newsletter, please feel free to send your contribution to info.us@micromedgroup.com. So I'm Dr. Longhi. I'm going to pass the floor, leave the floor to you to go through the questions, and thank you very much.
Okay, so I see that one person asked me, how do I apply in my everyday practice the lesson of all these studies? It's difficult to answer. It depends how much time you have and how many people you have working with you. Ideally, the best way is to have every day, let's say at 8 a.m. or 8 p.m., it depends, a summary, a quantitative summary of all the day, of all the data, knowing what to expect. So ideally, if there is the possibility, you can say, okay, today the mean ICP for this time period is 15. The CPP is 73, but then you ask a question. Is there a way to know if the patient has an intact autoregulation or not? So ideally, if you have time and if the heart of the patient is good, you may perform every day a test of autoregulation, because it's very difficult to obtain the PRX. And the PRX may have some confounders. So if you have time and you want to understand the autoregulation, you perform a MAP challenge by increasing mean arterial pressure of 10 to 15 mercuries for little amount of time, and you understand, okay, the patient is autoregulating. You may also understand autoregulation by integrating with the reduction in mean arterial pressure, increase in ICP, and this gives you an estimate. If you need to set up the best PaCO2, and you understand this patient is hyperemic, you may perform, again, reduction in PaCO2 by monitoring, if you have it, SJO2. I know that it's not perfect, but it's a starting point, and to use PbTO2. If you have EEG, you may, for example, see if you see changes in the AD ratio, even if to date I cannot tell you a real threshold. But the important is to get quantitative data and to test your patient every day. So little physiological tests that allow you to understand that patient at that moment. Since glucose metabolism is so important at the beginning, I would not try to reach a normal glycemia. 150, it's fine. I would not go below 100 in a patient with an acute TBI. This is one approach. If you have intracerebral microdialysis, but it's a rare application because it requires money and effort, you may test also CPP, PaCO2, even brain hyperoxia, and then see what happens to the lactate to pyruvate ratio. If you have the possibility, you can do it. A second question is, understand this question, because not all the hospitals can afford the entire spectrum of monitoring tools. So if I should rank them, okay, ICP, CPP, PBTO2, and EEG, in my opinion. If you have the possibility, you can combine ICP with brain temperature. I think that this would be a starting point. To study autoregulation, if you have, you can then add TCD. That is important for brain trauma. It may be more important for SAH patient. But for sure, ICP, oxygen, EEG, I think an important starting point.
It looks like you've answered all the questions. I'm gonna just give it another minute or so to see if anybody else has a last minute one. In the meanwhile, I'll also remind all the attendees that the video of this presentation will be posted on our website in about a week or so. So if you want to watch it again, it's going to be available there, or if one of your colleagues missed it, they can catch it on our website later on. So it looks like there's no more questions. So I'm going to thank you, Dr. Longhi, again very much for your very informative presentation. It was wonderful. And thanks to everybody that attended. We'll catch you on the next Brain Matters webinar. Thank you very much and have a great rest of your day.
Thanks a lot to all of you. Ciao.
Ciao, bye.